Solitary Fibrous Tumor of the Pleural Case Report by Ryan Islam, Elira Masca, Maria Vasquez, and Mark Meyer. Solitary fibrous tumors are mesenchymal neoplasms that are often indolent and asymptomatic. On occasion, they can present with associated paraneoplastic hypoglycemia or hypertrophic pulmonary osteoarthropathy. They have a tendency to grow within the body cavities but can be seen anywhere in the body. These tumors arise with equal incidence in men and women, usually in the 5th to 7th decades, however, have also been seen in the pediatric population. While their etiology is largely unknown, these tumors are characterized by a NAB2 STAT6 gene rearrangement, which seems to be pathognomonic and helps differentiate solitary fibrous tumors from other mesenchymal neoplasms. The mainstay of treatment is surgical resection. However, malignant transformation and an increased risk of recurrence and metastasis have been reported in some cases. Given the rarity of solitary fibrous tumors, however, it can be difficult to accurately predict these risk factors for aggressive behavior and to determine an appropriate surveillance protocol for patients with this diagnosis. We present the case of a 62-year-old male who presented with shortness of breath and was found to have a massive pleural solitary fibrous tumor with areas of dedifferentiation. A 62-year-old male presented to our hospital with progressive shortness of breath that had been ongoing for about 2 weeks. It had worsened 2 days prior to admission. He had no other accompanying symptoms. He denied any tobacco, alcohol, or illicit drug use. His past medical history was significant for hypertension and incidental lung nodule found in 2015, which was never worked up due to failure to follow up. On admission, a chest X-ray showed near complete opacification of the right hemithorax. CT scan of the chest demonstrated heterogeneous enhancement of a large intrathoracic mass. Biopsy confirmed diagnosis of solitary fibrous tumor. CT of the abdomen and pelvis was negative for metastatic disease. A decision was made to proceed with surgical resection. Following the surgery, his shortness of breath quickly resolved, and he was discharged in stable condition with instructions to follow up with hematology oncology. Solitary fibrous tumors are rare, clinically indolent mesenchymal neoplasms. A review of the literature indicates that solitary fibrous tumors that indicate high mitotic rates, nuclear polymorphism, areas of necrosis and hemorrhage, and infiltrated borders are associated with increased malignant potential. Additionally, dedifferentiated solitary fibrous tumors are a subset of solitary fibrous tumors that are characterized by the abrupt transition from low-grade to high-grade sarcomatoid transformation and are associated with worse prognosis. Our patient's tumor was actually characterized by areas of malignant transformation as well as dedifferentiation, which places him at a higher risk for local recurrence and distant metastasis. Given that these types of solitary fibrous tumors usually follow a more aggressive clinical course, continued surveillance even after resection seems prudent. Although there is limited clinical data, surveillance for at least 7 years has been recommended to the patient, as the median time to recurrence is 7 years and the median time for metastasis is 3 years. More data is needed in order to determine the appropriate surveillance protocol in this subset of solitary fibrous tumor patients following resection. In addition, more research is needed in the area of targeted therapies in the treatment of solitary fibrous tumors in patients with such high-risk features and for those who are unable to undergo surgical intervention. Thank you.